Hi, Matthew with the Healthcare Blog, here with a special chat. I have with me on the left Amy Parekh, and on the right Ankoor Shah. They are the head honchos of the clinical team at Included Health. Amy as the chief health officer, and I think Ankoor is the director of clinical excellence. I probably got that wrong. Something somewhere in that vein, close enough. Both MDs. Those of you who've been following this digital health stuff for a while know that Included Health is born as Grand Rounds, merged with Doctor on Demand and Included Health a few years back, and is one of those companies which is straddling the line between navigation and also direct care delivery. And these two in particular have thought a lot about what are the kinds of ways that we should be treating patients and managing their care in kind of a modern era. So we have a world in which we won't dive into too often. Those of you who read and see my stuff know that we have a disjointed, if non-existent, primary care world. We have a lot of specialists doing stuff in a disjointed manner. And a lot of hospitals that make a lot of money by doing intensive surgery, and probably none of that is the way that we would get to the best population health outcomes we wanted to. So great to see both you. Amy, we talked, I don't know, 18 months ago, a couple of years ago, about some of this stuff, but let's dive in a little bit. If we were to sort of start philosophically with you, and then we can go to Anchor, what are the major problems? So I described some at a very high level there, but what are the major problems that you see when, especially when you guys come to a new customer or a new population group that you're working on with Included Health? What's wrong? And then we'll talk about how we're going to fix it.
Great. Well, Matthew, first of all, thank you so much for having us. It's always fun to talk to you, whether we're doing it in person or virtually. Last time we had the joy of doing it in person, so maybe next time we'll bring that back up. Um, so I like to start at the highest level and then work my way down. So at the highest level, when we talk to a purchaser of healthcare, the problems are actually pretty basic. They pay too much money for not great outcomes. Period, full stop. And when I say they pay too much money for not great outcomes, what does that mean? That means for companies who are in retail or technology or their estate, let's say, and they have to like have firemen and women and policemen and women and teachers, the cost of their healthcare is becoming one of the number one costs that their CFOs have to deal with. It's going up year over year. This year, they're looking at double-digit increases. So it's a major line item in their cost thing. And that's just hard to run a business when you have such a big cost item. And then they're not getting the outcomes they deserve. And what does that mean? That means that their employees or their associates or the people that they have accountability towards to provide for their healthcare, they're living shorter, less healthy lives. They're unable to show up for work the way they want to. They're unable to show up for their lives and their families the way they want to. So we pay a lot. And if you're paying a lot, but then you get this amazing outcome, maybe you're okay with it actually. Because you're like, hey, I'm paying a lot, but my people are showing up to work every day, excited to be here, engaged. They can do the things they love for their families. They can snowboard if they want to. It's worth the money. But when you're paying a lot and not getting the outcomes, you've got a problem. So that's the fundamental problem our clients come to us with when they're thinking about, hey, we need to do something differently because we've been doing the same thing over and over again and not actually moving the needle on these two things. What does that mean at the member level? So that means that if you're a member, and I'm a member, right? I have to have health insurance, my family has health insurance, you're frustrated, you're annoyed, you're not living your best life. Healthcare, it's not something you wake up every day. I mean, for most people, maybe there's a few. You're not like, I can't wait to see the doctor today. I might be your doctor and really want to see you, but that's usually not the patient coming in, right? You're more like, this is something I'm doing because I want to lead a longer, healthier life. I want to do the things I love, and I want to prevent getting sick, or if I am sick, I want to prevent the suffering from it, and I want to get the best outcome. That is not the experience of members today. If you're a human in America, uh, and you will have a healthcare problem, 100% of you will. Sorry for that update, but 100% of people are going to have a healthcare need in their lifetime, and they leave with a frustrating, annoying, and not great result. And with so much money now being paid out of pocket by people, you also might go financially bankrupt because of your healthcare need. And so those are the problems. Good news, I'm an optimist at heart, so I think we can solve all of these problems. But that's the problem statement in my head. I don't know, Ankur, did I miss anything? Matthew, what would you add?
Yeah, it's really around the problem we're trying to solve is how is healthcare so different than every other part of our life? So it's really framing around we're trying to make healthcare like how we actually interact with other technology, like how I watch Netflix. And it's really what the consumer, what the patient wants, like what I want, what Amy wants, what you want, is care when we want it, where we want it, how we want it, that's affordable and very personalized. And that actually makes me healthier. And that's like a very demanding consumer. So we are really trying to orient, and I think that's the way to actually solve the problem is orient around that very demanding need for a patient that we all have. And if we create that experience for that, then all those other sequelae that Amy mentioned around cost and outcomes actually come true.
Okay, so two things about that. The first one is, and this is just sort of a factual question. We hear a lot about chronic disease. God knows we're hearing way too much about it now from our alleged Secretary of Health and Human Services. I call him alleged because there's a lot of things coming out of his mouth that aren't true. But I mean, I think it's true that the impact of chronic disease is clearly growing. And I want to know how much you're seeing that in your populations because you're saying it doesn't. It really the health meeting the rubber hits the road in the healthcare system when someone has a consistent demand for it. So that's a sort of a question as to how much the growth of that is impacting you. And then the sort of the wider question is when Owen started Ground Rounds back in the day, this was a company based on initially second opinions and then sort of specialty networks and then figuring out where people should go when they got sick, right? And we have for decades. I sat in Alan Hoban's class in 1990 at Stanford Business School explaining how, half the surgeries done shouldn't have been done. And, the variation in price from the Dartmouth people was just starting to get studied and found that, people were doing 3 times the amount of surgery at double the price in some areas compared to others. We've had people talking about that forever. So we don't seem to, have we done much about it globally? So first thing is, how sick are people? Are they getting sicker? And second, are we getting anywhere with this management of the sort of specialty chaos?
I'll give it a go. Uh, people have more chronic conditions, and we see that even in the commercial population. So I think, as you know about us, our current area of focus is working Americans and their families.
Yeah, I bullied your boss about this, and he said we're not doing Medicare yet. So, although it
Never.
does pay for navigation services now, and there are
Oh,
companies doing
okay.
it. So
I'm going to take that note, Tim. But
you should take all your business strategy from me. I assume. Okay, go on.
um so even in working Americans and their families, and Ankoor can probably speak to this, even in children, we are seeing an increase in chronic conditions. And one of the myths out there, I think, is actually that people with chronic conditions won't engage with care virtually. Like they're going to want to go in person to their clinicians. And we actually found in our virtual primary care practice, a number of the people who benefit the most from virtual care are people with 3 or more chronic conditions. And so that's the other sort of, I'd say, trend you're seeing that many people don't just have one chronic condition. So you've got an overall increase, like number of people with more than one chronic condition, I'd put it like 40%. And then more and more of those, though, don't just have one. Like you don't just have diabetes, you have diabetes and hypertension. Or you don't just have osteoarthritis, you have osteoarthritis and diabetes. And most of the time, you also have a behavioral health condition on top of those sort of chronic physical conditions. And so we're absolutely seeing that trend. And I think the way that's showing up is, we all talk about the delay in care that happened during COVID, and people just put stuff off, for all the right or, reasonable reasons. And now we're seeing trends go up a lot. We're seeing medical utilization go up. Some of that is this buildup. It's this buildup of chronic conditions that have not been managed well over the last, let's say, 3 to 4 years. And now we're seeing the implications of that on sort of more high cost needs of that population. So you're right on the needs of the population. They are increasing. Um, and if we manage them well, hopefully we can reverse that trend. I don't think it's irreversible in any way. Um, your second question, and I'm going to have to remind myself what it was.
It's about the management of sort of specialty care and hospital care in general, and the variation in that, and the variation in cost, and the variation in the types of, the idea that you get the same person in Seattle gets a different treatment they would get if they're in Miami, that kind of
I
that
think
kind
we
of thing.
saw a lot of opportunity there. So, what Included has said is that within a broad network, often a PPO broad network, we can steer you, the member, to the best match clinician for you. And that's a lot of the way we drive savings for our clients, honestly. We sort of minimize the variation of the quality of clinicians that a population is seeing at scale. And that's a huge driver of the value we give to our clients. I think if you were to look America-wide at those 160 million people who get their insurance from their employers, that variation is still stark, especially in places like PPO networks, because these are just broad networks. And there's very little reason for a plan to sort of narrow that network, right? So still a lot of room to go.
And even where they narrow it in the HMO network, I'm not sure they've done the sort of rigorous scientific backing about who's in the network and not based on quality and cost as opposed to who signed up or who was going to sort
But
of.
there's an inherent conflict there, right? They want to have a network, they care a lot about costs. Like, do they also care about quality? There's just inherent when you are owning the network and the one that's measuring the quality and cost, there's a little bit of a conflict based on that.
So, Aaron, let's dive into that a little bit. So, what is your philosophy about how you and there's a lot of people have a lot of moving parts here, but what's your philosophy about how you are dealing with clinical excellence amongst the people you choose? So, how do you start included? And obviously, you've done this in your real life as a doctor, as a pediatrician. I know you were at Accenture looking at this for health systems. How are you thinking about fixing this issue of sort of clinical variation and lack of clinical excellence and quality in a specialty network?
Yeah. So the framework we use is like if you kind of go down first is safety. Like, are we ensuring that people are actually connected and getting to safe care? And then you get to actually what is the quality of care they're receiving and the effectiveness of that care, which is now in two different arenas. Quality of care is probably evidence-based care that is being delivered that we can measure and see. And then are we actually driving towards better outcomes or reduced utilization? So, for example, in our virtual urgent care practice, we're actually resolving over 95% of cases that you do not need to go to a brick and mortar urgent care or ER. So that is a metric because it solves a member problem, solves a patient problem, and you're delivering right care. And this is where I think we are really pushing the innovation bubble because traditionally, like healthcare metrics haven't changed in decades. Like HEDIS metric is frankly so it's a little uninspiring. And so if we reorient to we want the member to have actually healthier days, at the end of the day, it's about adding more healthy days in your week or in your month. And if we use that as our orientation, then we're able to say, all right, what are the interventions that drive that? So that's around first safety, then quality, then effectiveness, and then actually cost. So what Amy was mentioning before, usually what we've seen in the industry is the flip. It's cost first, but versus value is really quality over cost. So it's really using that framework, whether it's the services we deliver, and we're able to then innovate a lot more, be more AI first in that same approach, or how we evaluate other provider networks and other kind of care delivery systems.
So let me sort of I get that for the specialty network. Obviously, a lot of this stuff is about and we mentioned the increase in chronic illness, and there are obviously other demands on the system. We mentioned behavioral health, mental health, which the demands have gone up dramatically. We know, well, either we're counting them better, or we know the rates of depression, anxiety, went up dramatically since the pandemic, and probably haven't gone down since the election. Be my guess. So you've got the sort of the output, how you're managing the specialist network and the hospitals and trying to rate them on these different measures, and we can dive in a little bit more as to how you're doing that. But on the input side, most you've got a lot of issues coming through, maybe coming through primary care, and maybe not, maybe going straight to specialty care. How there's this sort of philosophy that, the Kaisers of the world have had forever. And if you go, the policy wonks about it. If we could give everyone primary care and we could manage their primary care and get them to behave properly, blah, blah, all this stuff, it would save us a lot more money in the long run. And we'd have better health, healthier populations towards the end. Given the problems we have with, chronic illness and elsewhere, is that something we can actually do? Number one. And number two, how are you thinking about doing it given the sort of the virtual primary care network that you're running?
Yeah. Do you want to start?
Yeah.
You want me to start?
Well, I'll say one thing that we didn't mention is with the rising chronic disease, there's a demand problem, right? There's increasing demand. There's actually a supply problem as well. So the
Sure.
reason why much of this is happening is you actually don't have access to high quality primary care that's longitudinal in nature. And so I think one thing that Amy and I and all of us at Include Health are excited about is this first dollar telehealth coverage that was recently passed, which then gives employers an opportunity to expand access while still considering affordability for the member for different type of care for virtual care services, including primary care. So that is probably like the first thing is around access and then ensuring that longitudinal care relationship where you're able to not stick to a 15-minute visit where you have to talk about everything. We're on this journey together to manage your chronic conditions.
Yeah, I guess so Ankoor mentioned access as one key way we get anyone who wants it to have high quality primary care. But I also think we're at this really opportune moment. And maybe it'll require us to redefine what we mean by primary care. Because primary care is a tool that we in healthcare use. It's like a very healthcare jargony word, actually. Like if you were to ask 5 people on the street, hey, what's primary care? I bet you'd get 5 different answers, and some people would just stare at you, be like, I don't know, what's secondary care? Like, you tell me. And what it means in my head is that you have somebody who you trust that lives within the highway that is healthcare, that can help you make decisions about your healthcare to achieve your own goals. And they come with some level of expertise. So they actually know things like, hey, you should use this medicine or this medicine. So that's how I define primary care, that most of the time it's a person. But hey, we're like really in this world of AI right now. And I know you're going to talk to Owen at some point about how we're using AI. But could some of that be taken over by a tool that is not another human, but is supported by a human? I mean, I think this is like the first time in my 20 years of working healthcare that I'm like, maybe there is a solution to the supply problem that Ankur was talking about. We've done a lot by enabling virtual access. So if you're rural, you can get access. But the next phase is maybe not everything has to go through a human. Maybe you can have a trusted relationship with the AI plus EQ, right? That actually gets you to better health because that's the goal. And so I think it's going to be an interesting decade of really trying to define what primary care means from the member or the person perspective and not necessarily from the healthcare system's perspective, which is always the way we want to define everything. And then we're going to be able to drive those outcomes because the proof points are in countries that have a higher general practitioner or primary care ratio to population, in places like in Kaiser or in other vertically integrated healthcare delivery systems where people start with their primary care doctor before going to a specialist, they get better outcomes. They live longer, healthier lives. And that's really what we're trying to go for. Primary care is a major tool to get there. And now we have this thing called AI where maybe we can scale it better. Maybe we can make it more personalized for people. So I'm very excited for this next era of primary care.
Well, that's because they're all healthy and sitting in Portugal with their primary care clinics and they're eating their sardines drowned in olive oil and drinking red wine and eating grapes and enjoying themselves. So before we get there, I think that there's a ton of and look, I'm a big believer in primary care. I mean, I wrote this piece just saying that we should give every primary care doctor 600 patients and $1.2 million and let them get on with it, and that would probably improve healthcare. But and if you look at the Humana data about how they manage their value-based care versus their other care, they're spending nearly 3 times as much on primary care and seem to be getting better results and yada yada. So I think the policy wonks, we're all bought in. But there's a couple of things before you even put AI on the side for the moment. What you guys have been doing and included, and obviously you're not the only people who've been doing this for many years, is providing telehealth-based primary care. And there seems to be a couple of issues there. One is getting past the regulation of, a doctor has to be licensed in New Jersey to see somebody in New Jersey. That whole piece seems to be really gummed up by the traditional healthcare medical system and the regulation. And the other one is that there is still, I think, a fair amount of uncertainty. And this is why, in my view, and I love your comments on this, it's been a bit tricky to get non-mental health telehealth really going as to what can you do in a virtual consult that and where do you need to actually physically go and touch somebody, touch a human. So I love your comments on both of those. Are we getting better on the regulation side? Is this going to go away as a problem, let alone before we start doing AI across state lines? So what are we going to do with AI? And then on the second question here is how do we convince people, or how are you working to actually convince people that this virtual primary care works, even if I can't physically touch you?
Yeah, I'll start and then Ankoor add.
Yeah.
So I don't think state licensing boards are going anywhere. States need money, budgets. Like there's a whole reason this industry exists, right? And so I think it doesn't go anywhere. I do think it.
So all your doctors still have to be licensed in 50 states, or
Oh yeah,
that
and
BS has to happen.
That's part of the reason to Ankoor, like Ankoor said this before. We at Included have this advantage of scale that is really real. Like we have been there's lots of like special sauces at this company. One of them is we know how to license people. We know how to do it efficiently. We know exactly how many licenses you need when you come on this door, and we get them for you. And it's
you're very good at a necessary but totally useless.
And it's built up over time.
50 state practice 24/7, 365.
And that is something we.
All right. So we assume that the way to fix that is you have to regulate, bribe, legislate, figure out your way through it. And you've done that. We're not going to change that. I can't stop my AI box in the corner over there and do all 50 states immediately from Tokyo or wherever. So let's talk about the second then. How do you convince people that primary care can be done without being touched?
Well, I think most people, if I'm being super honest, most people believe it once they do it. And there are advantages and disadvantages of both. So what is the advantage of the virtual over the bricks and mortar? Frequency, quickly getting in, not having to wait 60 days. And you get to see things in people's homes that you don't get to see when they come in your office if you're a doctor. So you can actually say, hey, open your medicine cabinet, show me your pills. Hey, where's that scale again that you tell me you're standing on every day? So there's a whole bunch of stuff, because we're often like, if you're like gold standards in person, then everything else is not that. But actually, you could argue there's a bunch of stuff we can do virtually that you can't do bricks and mortar. So how do we think of those tools in primary care? The second is, one, monitoring is getting a lot better now. So like you can listen to somebody's heart virtually. You can listen to somebody's lungs virtually. You can look in their ears. I know many parents have bought the little attachment for their phones where they can just send a picture in of the tympanous membrane, so they can be like, yep, ear infection, no ear infection, done. So technology in the home has moved quite a bit forward in the last 5 years. So there's a bunch of stuff you don't actually need to lay hands on the patient. That being said, there's still certain things that we need to do in person. Classic example, a well woman exam. There are parts of that exam that have to be done in person. And so for those, we do refer to high quality in-person providers. Those are usually things that don't have to be done very frequently. That's at most a once a year, usually. Most of the time it's once every 3 years type thing. So we can get that done for you. So I think the issue is we want both as members. We want to be able to access virtually and in person when that's needed. And where does the relationship live? It's easier for the relationship to live virtually, actually, because of the frequency of visits, the ease of access. And then the in-person could become more like a commodity. You get it done when you need to get it done. I do think it's going to take time for people to really believe that model. Right now it's working when a friend tells you it's worked for them, or you do it yourself. But Ankoor, I mean,
What's interesting is if you ask doctors, probably even a doctor in your family, they're providing non-office care visits all the time. Most of our lives is probably, or a lot of our lives is actually caring for our family and friends through asynchronous or virtual visits. That's kind of off the grid.
Just send them a bill. They'll stop.
Yeah.
They'll
And
stop bothering you.
we still want to be loved
yeah,
by our
yeah,
families,
that's
Matthew.
true. And
Overrated. Although
and
apparently it's
I
good for
would
you.
argue my member satisfaction is great when I do that. I feel confident that I'm able to because we actually, if we were to deconstruct a primary care visit or any visit, it's trust, so relationships, data, and decisions. And we've been focused on getting the data part in person with through wearables actually, and what's the value of some of that data compared to other parts, you have an opportunity to change. And then decisions which require follow-up and close connection to trust. So actually, if we were to deconstruct what a primary care visit is, you could easily do it in a different way. And I would actually push the boundary across, it's not brick and mortar versus virtual. It is, can we reimagine the care experience to be longitudinal and say what parts should be async, what parts should be in person, what parts should be virtual, where should technology take the lead, and where should we take the humans take the lead? And a perfect example when we talked about AI is when you're prescribed a new medicine, generally adherence, if there's an issue, drops after the first week. I don't like the taste, I have this side effect. How often do you get a call from your doctor a week after you start taking the medication that how is it going? Versus you could have an AI assistant enable a 1 week after every new medication. Hey, how's it going? Any issues? And then quickly change and quickly have adherence. So it's really not the paradigm between brick and mortar virtual. It's traditional healthcare and a new way forward of redefining what care should be.
Yeah, I can recommend about 15 companies who think they can make that call for you would happily go work for Included Health on that basis. There's, a ton of interest. And I think it is generally, correct that we can do a lot more. I'm a little, I'm not saying, I wasn't, disappointed is probably the right word, actually. I'm probably disappointed is the uptake of some of these remote tools. I mean, the folks at Taito Care have had this thing that you can pass around and stick in your nose and your ears and whatever and put on your chest. There was a company called MedWand, which, good God, they won the Health 2.0 launch. So that must have been 2015, 2016. And they never got the thing to market. I'm actually very surprised there isn't more like a consumer good of a thing. I know there's the attachment to the phone you can stick in your ear that got bought by J&J. I can't remember who it was originally called, but it was another of those early rock health companies, And there's a bunch of stuff that you could do that. I'm a little surprised about how little there is of that, although I know people are using the Apple Watch now, and there's this thing about Whoop and the blood pressure and the rest of it. But I mean, I'm really, RFK Jr. for his trouble has been talking about wearables. I'm a little surprised about how little there is for sort of the exam stuff that could be added on. I mean, I still have, my doctor looks at my chest and makes me lift my shirt up and listens to my heart and goes, yes, you still have the same murmur you had 5 years ago. I'm really surprised that we haven't really aggressively more pushed that stuff on people.
Yeah,
so my editorial, maybe you guys would
cost. I think as the price of those things come down, I do think they'll get more adapted. I think they were priced high, and so if you put yourself in the shoes of the purchaser, I think I hate this term, but like the ROI might not have felt like it was there. But
I'm actually surprised it's not more of a consumer good. I would think that
yeah, just like people would want this for their own
would want to do that, and then it would plug into a video as it rather than run. But let's go to the net. I mean, for people who are basically healthy, and maybe you should come in and maybe you should get your chest listened to every so often. But I'm thinking about for people who have more long-term chronic conditions. How do you philosophically and how does your medical group think about doing this sort of remote patient monitoring? Obviously, we have, the blood pressure stuff, which I've been recently whining about because I can't get a correct reading. I've had different readings from my doctor, a nurse at a health fair, and two different, devices I've been using. I either have very high blood pressure or my blood pressure is too low. I'm not sure. But that does vary tremendously. But obviously, you have people with diabetes and blood sugar issues and A1C, and and then obviously you have a bunch of other conditions that people are trying to measure, including things like pain and what have you, as remote patient monitoring. that's where I think you mentioned, Ankoor, getting into sort of, continuous, there's async and there's kind of continuous monitoring. How do you think about what's the sort of included health philosophy about chronically ill patients with those conditions with those right kind of tools? What are you doing about that? And how do you think it's sort of helping that demand side, as it were, for care?
I'd love to share kind of where we are and where we're going also
Sure.
is right now we're able to have take blood pressure and diabetes, for example, or a couple chronic illnesses. You actually have ways of monitoring that outside of the virtual visit. So that could be your blood pressure cuff, and then you're taking your blood pressure, you're actually putting that in the app and letting your doctor know. Your doctor says, "This is your care plan. I need you to actually do this." And then you're doing those tasks and then having those kind of communications back and forth or a visit. Similarly, you're getting your labs drawn, and then that information is coming back to the doc and or to the care team, and you're working together. So that is essentially taking what is a hard process currently in person. Like I have to go to them or I have to like figure out a schedule. It's painful and really taking the friction out of what the current process is. But I think what excites us is let's take away the current process. Like, what's the future process as well? So there's two things. One is what we're doing already, which is how often, for example, have you gone to a different healthcare like situation and you got your blood pressure taken, or you actually got labs, and then you went back to primary care and you're repeating a test. And there's a lot of waste and like trouble with that. So some of it is just pure our investment in technology and upgrading to like a consumer grade electronic health record that has interoperability. So we're able to actually see other places you're getting care and use that information for your care plan currently around chronic disease. And number two is where where the future is really around integrating other data that you have as a person, whether that's from your Apple Watch, your Fitbit. There's more and more kind of tools, and how do we and really integrating that to not necessarily only your care team. Like, so this is going to be a little future facing forward. Uh, you could actually train an AI tool around some parameters. I'm a doctor. I would love for you to be in these parameters. And once you're out, like let me know. And then you're able to engage with included health in a way that is transformative, that really helps you kind of keep aligned in certain metrics. And then as soon as you're a little off course or something goes, you have the power of a 50 state 24/7 practice behind you.
Yeah, I think the only thing I'd add is a little bit of data. So um, we actually, it was interesting. I do think there's this belief that if you're a young, healthy person, virtual works, and if you have chronic disease, it doesn't. It's actually the opposite is what we see. People with chronic conditions love virtual. Why? Because often they are also seeing specialists. So if you have to go in to see your specialist, like let's say you have a cancer diagnosis, you're probably going in person to see your oncologist every now and then you don't actually want to also go in person to see your primary care doctor. And often what happens is people just stop doing the primary care things. They stop managing their diabetes, their hypertension, because they're so focused on this really sort of big condition. And so having a virtual primary care doctor actually keeps them healthy on some of their chronic stuff. So what we find is patients with complexity actually really prefer doing this primary care piece of their care virtually. The second is we have care case and disease management. So the most complex patients need a lot more than visit-based care. They often need a social worker because some of what drives some of the complexity in American illness is I don't have access to the food types that I need to eat. They need behavioral health support. They actually need a couple of specialists, and we want to make sure they're all high quality. And so, um, using our tools and that team for the most complex members is actually one of the ways we drive this value. So it's primary care for sure, but it's what else beyond just visit-based traditional primary care do people need to manage their chronic illness, given the situation that they happen to find themselves in, um, is sort of the push I would make.
Yeah, I mean, I think that there's the redefinition of primary care as a bunch of different stuff, including navigation and monitoring, but also the behavioral health aspect coming in, and quarterbacking that team approach. It's something we all talked about for a long time, but again, doesn't happen enough. And I guess my soapbox is that I built this. I wrote this paper and built this chart 5 years ago now called the continuous clinic, which had all the bits, which had basically the telehealth doctors in the bunker at one end, but it was all the monitoring at the other end of the patient based on where they were, right? And this is going back to when people in COVID were thinking about being in hotels, and you had to monitor them for blood pressure and for pulse ox and all that kind of stuff, where you didn't actually, they could be in a hospital, though a lot of people were doing that in hospitals, and a lot of people were doing it outside of hospitals. And with that kind of philosophy, there are a lot of things here you can do. Now, obviously, you have to get people to actually monitor their blood pressure. You have to get them to the point where they actually are taking their blood glucose or, monitoring whatever it is. And there is that division between somebody who's basically healthy and doesn't have a problem and somebody who has now got a chronic disease. And where do you figure that out? But it does seem to be that's the future of sort of primary care based, healthy living needs to be that we're monitoring people at the rate they need to be monitored. So if you're a healthy person with an Apple Watch, maybe you get into your 50s and get AFib and it starts getting picked up or whatever. But obviously, if you have developed type 2 diabetes or whatever, we can start really focusing on you more and more. And it seems to me that's exactly where you guys are going. So
yeah. So like we started with, we should just take our strategy from you, Matthew. Right?
Yeah.
I don't know why I don't want to do anything else.
No, it is fun because you mentioned healthy living. That's the words I hear our members and patients talking about, as opposed to, as Amy mentioned, this whole idea of like primary care and that's a construct we've created. And then we're trying to fit into that versus what truly does a family want? They want to feel secure. They want to feel confident that they're going to get healthier and their mind, body, and wallet are going to get taken care of. And so if you start just with that problem statement and then build towards that, you end up creating something like a continuous clinic that actually includes a lot of financial advocacy that has nothing to do with traditional brick and mortar. And then when you do that, you actually end up improving health outcomes, thereby reducing utilization and thereby reducing costs. So that is really the hypothesis and thesis that I think is so different than how we see this problem being solved because it's starting from different points. You're either starting from the cost end or even you're starting from the quality part of specialty tiering versus it's actually about the family and the member.
So I think that's dead right. I do want to ask you. We sit here, we say this. It all sounds great. You guys have got, I think, Amy, I want to say 15 million members now. Something like that. How many?
Yeah, and sort of if you think of we have like two categories of people. There are people who have access to our virtual services. That's actually on the range of like 50 million people. But if you think of the people who have access to our all-included care or navigation plus virtual care delivery, that is on the order of 50 million people.
Okay, so that's a decent number, but there are 340 million Americans. Some of whom are about to get less care and less access to care than they had before, given what's just happened to Medicaid. You have a number of competitors, but even if you add up all the people who are into the Kaisers of the world and other players like doing sort of integrated primary care across the board, it's still a minority of Americans. The thing we've talked about sounds great, but it's taken a while, as we said. I kind of always kid that whenever someone comes up with a great new way of doing primary care, I said, yeah, Sidney Garfield was doing this in 1936 in the desert, wherever he was before he started Kaiser, and nearly 80 years later, we haven't really got there yet. So what's your sense for the pace at which we might get to this kind of near-term future we've been talking about?
Oh, I always think it'll be faster than it is, right? But there's that saying, you always do less than you think you will in 1 year, and then you always do more than you think you will in 5 to 10 years. And if I reflect on my 7 years included, that's sort of how I feel. Like do I always want to grow faster? Do I want to be able to give this service to more people than we are today? 100%, absolutely, all the time. Everyone in my family asks me, when do I get included health? So like, this is like the thing. So I wish it was faster. I wish it was like immediate. But given that that's not how healthcare works, right? The biggest problem in healthcare is not a lack of ideas, it's a lack of scaling those ideas. We've been lucky and I think good enough at what we do to grow consistently year over year over year. So I think we were just sort of talking about this whole thing started, just in 2011. So, but in some ways we're old. We've been around for a while, but I have a 17-year-old at home. So I'll tell you, we are also still a baby. Um, and so, we've for just being a 14-year-old company, we are now serving 15 million Americans. That's a million Americans a year. And again, we want to hit 350. I get you, but that that's actually pretty significant growth. And my hope is, and we've always said this, our mission is to raise the standard of healthcare for everyone. And we've always said we will never be able to do that on our own. We want people to copy what we are doing because ultimately imitation is the best form of flattery. So if every health plan in the world starts doing what we're doing for people in America, that's great. That's what our hope is to show the world this model works. You can get better outcomes at lower costs. And we're going to keep doing it. We're going to do it for more people every year, but we encourage others to do it also. And there's some policy things like what's in the BBB, there's lots there, but this idea that employers now have flexibility around allowing their members to uh, access telehealth at low or no cost without putting their HSAs at risk and high deductible health plans, those are moves to increase access, to make it easier for people to get the kind of services that we offer and that hopefully others offer as well.
So let's end Anchor with you on a couple of sort of the trickier parts. So we can sit here and talk about motherhood apple pie and fixing primary care, and I think we're all in huge agreement about that. We're all going, why the hell does this take forever? Why don't health plans really do it? I'm a member of a famous California health plan beginning with blue with some kind of weapon or defensive weapon involved in it. And I always go, why do these guys, and I know you guys work with them and some of your clients, I'm always saying, why are they not insisting on, knowing more about the stuff I'm doing? And why don't they seem to know, that I've been to a primary care visit here and they're offering me another one there? And, there's all these complexities within the payer level. People move between plans all the time. It's all chaos and the rest of it. But, you can see your way through to getting a primary care system, hopefully. And if you add more AI and more tools to support it, which I think is coming, I've just been playing around with this primary care mental health, mental health AI thing called Ash, which just got released yesterday. And, I've been inventing all kinds of psychoses to see how it's doing. And it's doing pretty well, So I think there's a huge opportunity there for, AI monitoring AI and AI supported primary care with clinicians. But the bit we spend real money on, as we know, is especially care, right? We spend money on expensive drugs, we spend money on expensive surgery, we spend money on cancer, basically. What's your philosophy, and what are you guys actually doing about those costs?
I spent a lot of time thinking about that, and I think there is this idea that we could cut such a large amount of these high costs by doing kind of these marginal things. So I think for the first step is acknowledging certain people need higher cost services and have complex needs like cancer care, for example, or those with multiple complex and rare conditions. And really acknowledging some of that is they're getting evidence-based care that is the most cost-effective care that exists and that is actually transformational. Gene therapy is actually transformational, and it is incredibly expensive. And that is a problem we need to figure out writ large. So there is that avenue. But oh my goodness, there is so much opportunity in ensuring that you could have the right type of care, right level, and high quality care that's cost effective. And the way, like centering again on the member. So what's actually easier for the member? And this is where, in our partnership and work with CalPERS and Blue Shield of California, we're actually operationalizing these ideas. Matthew, some of these ideas are as old as apple pie, site of care steerage, moving to biosimilars, all of these things we've said. How do you actually do it? How do you actually engage a member and share and show why it's easier and better for them as well as for the health plan? So that's really kind of where we are like focusing our energy is how do you make the right decision the easy decision? And it's not by creating more friction for the wrong decision, which is traditionally. the way. It's actually making the right decision much more frictionless through technology, through better experience, and through wraparound care.
Yeah, I'll add a couple of little things. One is to your push on why is primary care effective? It's actually effective because you actually usually avoid specialty care if you do it well. And so like there's small things that you can do. So we do this today. If you're looking for a specialist, we'll often ask you, have you already seen your primary care doctor for this? So how do we give those nudges at the right time? So don't go straight to the orthopedic surgeon. Talk about your need to your primary care doctor first, and then let them help you decide if you really need to go to a surgeon who will most likely operate, right? That's usually a course that might be taken there. So that's one sort of big lever to decrease specialty use over the time. And then, I'll just go back to where we started on quality really matters. High quality specialists are less likely to do inappropriate procedures and to use the high cost inappropriate drugs. And so we still, at our core, believe that by driving to quality, you will decrease long-term costs. And so to Ankur's point, you just need specialty care. Let's just call it. Many people need specialty care, but can we make sure that when you need specialty care, you're getting the expert opinion to make sure that you're getting the care you actually need? And when you see that specialist, you're seeing the high quality specialist who's not going to do an inappropriate surgery, who's not going to get an MRI if you don't need an MRI, who's not going to prescribe this med just because it's expensive, but actually use the med that's more likely to work for you. So that's still our core of how we affect specialty cost. And turns out now we have good evidence that it actually works. So that has been built up over these last few years.
So on that point, two quick related notes. One is there's a lot of fuss at the moment about people being denied care by AI in plans and whatever. And there's, you're seeing there's the great cancer, the great TikTok meme of the cancer plastic surgeon specialist doing her thing and having to talk to the United
Oh,
Dr.
yeah.
Raymond. Well, like,
Like in the middle of the OR, right? I think.
there's one of she's come out of the OR or whatever.
Yeah.
There's Elizabeth Potter in it, and there's a propaganda war which is clearly being lost by the health plans on that at the moment. So how do you avoid getting what you just said, which all sounds very sensible, being sort of bundled in with, well, these people are just denying us care because we want this and want that?
I I really, and might sound simple, but we're solving for a different problem. So there's actually what's going on in the industry is AI versus AI. Large hospital systems, their goal or a goal is to rev up rev cycle management. So they're actually deploying AI to do that, or their goal is productivity. They're revving up AI to solve that problem. And then on the plan side, it's actually like a better audit function of those codings. So it's AI versus AI. And I don't hear a patient or family anywhere in that conversation. So it really goes to, well, we're actually trying to solve for an easier, simpler healthcare experience for the member. So when we think about what our member-facing AI will do, for example, hey, how's that prescription? It's like, how are those new meds doing? It's just such a different framework of building this tool that supports this overall vision.
Yeah. And I would just add, to me, it comes down to trust.
Yeah.
So, we've always, I think Owen's vision at the beginning, part of why I love this place is everybody kind of wants a doctor in their family, a doctor that they love and they trust, and that's going to do right by them. That's why my family texts me whether or not I want them to. It's probably why Ankoor's family does the same thing. And they feel like I've got their best interest at heart. And if I were to say, actually, you can do this in your home and you don't have to drive, or you can, or if you want, you go in person, but it's going to be kind of a hassle. It's not that much better. They're going to listen to me. Now that trust has to be honored. And so it is not something you take lightly as a physician or a clinician, as a caretaker for another human being. You got to really, it's a privilege to have that trust. But part of why we're so excited about this third way, like we're not the health plan, we're not the provider. We're trying to be both things to you as a person, is because if you trust us, and it will take a lot for us to earn that trust, Maybe we're going to have to solve a bunch of your problems. Maybe we're going to have to help you battle a bill that you don't think you need to pay and you don't need to pay. But if you trust us, and if we should be trusted, then maybe it won't come across as we're just trying to take something away from you that you need and deserve, but actually that we've got your best interest in mind. And like turns out this other alternative path is now that's a big if, and to maybe I'm living too much in la la land. But that's the optimism. That's what we all want. And I think we can do it. And I think it's probably going to be a third party like us that we're not coming in with a lot of baggage. Like we're trying to do what's right.
Yeah, and that's the real. I mean, ultimate question is can anybody sort of have this brand of being a trusted person as the ally of the consumer and doing the right thing? Because people don't understand how any of this stuff works, as we said earlier on, and there's clearly not that 50 years after the Dartmouth stuff, there's the Dartmouth research. There's still a lack of understanding about the variation and, for that matter, the lack of safety. You brought that up briefly, Ankoor, in American healthcare. And I think the more that you could have somebody to trust you, guide you around the system, the better. Mike McGee, who comes on my podcast occasionally and writes on the blog a lot, says that the role of doctors is to assuage the fear and worry of their patients. And you've got to have that part, and maybe that requires the hands-on. Maybe it doesn't. Maybe it can be done virtually. Maybe it can be done as a thing of trust, as a notion of trust. But that's the part to me which is part of it, right? But you've got to help people feel that someone's is on their side through the system. But then also you have to, you have the harder data part of managing what's going on at the back end of the system, which, as we said, is still super complex, and a lot of it's, inefficient, ineffective, and in some cases harmful. So we have to work on that. All right. Last thing for both of you. So, okay, let's, it's always, we want it to be done in the year. It's always going to take 10 years, but in 10 years, or 5 to 10 years, what do you think the the included health experience will mean to people who are part of it? What do you think included health will be doing that is maybe not massively different to what you're doing today, but what types of things do you think you'll be doing? And do you think you'll be the sort of the understood to be the medical group or the care provider for the people, the primary care provider for people you're working with?
Yes to the second question. I would say 10 years is an interesting time frame. So first of all, I do hope more types of populations have access to our services. So I think we'll continue to be offering sort of this type of care for working Americans and families. I hope more people can get it through their employer or through whoever purchases their health care for them. Perhaps we will, also be able to offer these services to patients who get their health plan through the government in various ways. I think if we do what we say we're going to do and we do it well, you're going to have a team, and that team will be both technology and humans that you actually trust to be by your side in managing this thing you call your healthy life. And it will be both through visits, and I think we'll be doing more types of visits. So we already do primary care, behavioral health, urgent care 24/7, all 50 states. There's probably a whole bunch of specialty care we should be able to do for you virtually as well. Like you kind of don't need to go into the office for a lot of stuff that people do today. We will be able to more seamlessly than we do today guide you to in-person care when you need to. So when you end up going to that in-person care, which we send you today, I don't want you to have to repeat your story. I want it to feel integrated in a way that I think we have opportunity towards. So you need that well woman exam, you show up, and maybe you won't need that because there's some good, interesting stuff being tested now. But if you do, you go in and the person who's doing that knows you, knows your past results, is really confirming things for you. It feels like an included health visit versus I'm being handed off between different provider groups, in person, virtual. When something bad happens to you or your family in the healthcare realm, you've got somebody by your side. So the new stuff that pops up, you can easily call us. And people don't get bankrupt because we're helping them manage the cost side of this equation too. So it's not really that different from what we do today, but I want to do it all better. I want to do it all more seamlessly, and I want to do it across more things, that all included perspective for more people. I don't know, Ankoor, is there something I missed?
It's interesting you say 10 years. I would love like if by doing all that, when people hear about included health, they'll think this seamless member or like healthcare done right and easy, and I'm gonna be taken care of. Like how I think about healthcare, how we think about healthcare now is pretty horrible. How I think about a luxury hotel experience or going to Disney World is very much, or even Costco is very much different.
I mean, Disney World is horrible, but that's by the by.
Yeah, yeah, definitely. But it's actually compare actually included health is that experience for me. And it doesn't mean we're doing it. We've created a model that they're doing the included health model over there. So that's why I'm going to go there.
That's great. All right, fantastic. Well, I've been speaking with Ankoor Shah. He's the VP of Clinical Excellence, and Amy Parekh, who's the Chief Health Officer at Included Health. We're talking about their model. We talked about a bunch of stuff, but there's a bunch of stuff we didn't talk about. We didn't talk about health span longevity. We didn't mention GLP-1s, all kinds of good stuff. So hopefully you two will come back on and we talk about that next time.
Yes. Talk to you
All
soon.
right.
Thank you.
Thanks to both of you.